How do you like this for social distancing, huh? I hope you're enjoying dinner, and I hope you're enjoying the annual meeting. On behalf of CME Outfitters, I'd like to thank you for joining us for today's symposium entitled Keeping Things Moving on the Treatment of Chronic Idiopathic Constipation, Exploring the Evidence and Guidelines Through Case Studies. This symposium is supported by an educational grant provided by Takeda Pharmaceuticals. Today's CME CE activity is also eligible for ABIM mock points. So please make sure to engage in today's event, answer polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit for your mock points. You can also claim this activity as CME for MIPS improvement as well. I'd also like to welcome all of our colleagues who are joining us remotely on the web and social media streams. Our goal is to make this as very interactive as possible. Please send us your questions throughout the program and in the platform or as a tweet. We'll also be monitoring all the social media feeds and all of the different technologies and responding to your questions as best we can within the limitations of the time that we have, of course. My name is William Shea. If we can go back for one second, that's fine. And I'm joined tonight by, there we go. So I'm William Shea. I'm a professor of gastroenterology and nutrition sciences at Michigan Medicine in Ann Arbor, and I help to run a number of clinical programs there. I'm joined by Dr. Lucy Harris, who's an associate professor and consultant at the Mayo Clinic in Scottsdale. And finally, we're very pleased to have Dr. Michael Camilleri, who's the Atherton and Winifred Bean Professor of Medicine, Pharmacology, and Physiology at the Mayo Clinic in Rochester. Our learning objectives for this evening, there we go, are to accurately diagnose chronic idiopathic constipation, differentiating it from irritable bowel syndrome with constipation. And secondly, to evaluate the characteristics of therapy used in the management of chronic idiopathic constipation. And thirdly, develop a comprehensive treatment strategy for patients with CIC, construed from evidence and clinical guidelines. So let's get started. First, we just want to be clear about the clinical and economic impact of this condition on our patients. Realize that this is one of the most prevalent GI complaints affecting over 35 million US adults, so 1 in 7 people. Approximately 7 of 10 people experienced CIC symptoms for at least 2 years. So these patients that suffer with these complaints tend to have chronic problems with constipation. And it's been estimated to affect twice as many women as men. It's the 4th most common GI symptom promoting outpatient clinic visits, resulting in an astounding more than 3 million outpatient clinic visits per year in the United States. And in 2013, the direct medical costs for chronic constipation ranged anywhere from $1,900 to over $7,500 per patient per year. In 2011, the national cost for emergency room visits exceeded $1.5 billion, so a very expensive problem. In terms of the impact on quality of life, 60% of patients indicated that CIC interfered with their ability to conduct their personal or professional activities. 25% missed an average of 60 days of work or school per year, if you can believe that. The most common emotional symptom is frustration, followed by acceptance. And this gets to the sort of linkage between some of these points, which is that if you were to have asked me, I'm not sure I would have estimated that 25% missed an average of 60 days. And this is one of the frustrations for patients, is that they feel that we as healthcare providers oftentimes don't understand the level of suffering that they experience as a consequence of their constipation. So to talk us through accurate diagnosis of CIC and differentiating CIC from IBS-C, I'd like to introduce Lucy Harris. Lucy?
Thank you. Thank you, Bill. Thank you all for being here tonight. Appreciate it. It's a long day. So this patient, Richard, has come to see you. He's a 69-year-old gentleman, and he has a history of lifelong constipation that's gotten worse over the past 2 years. His bowel movements are type 1 to 3 on the Bristol stool form scale, so rather lumpy, and he has bowel movements about twice a week. He tells you he has frequent straining and some bloating, but he denies having any bleeding or any weight loss. He's tried multiple over-the-counter laxatives like many of the patients that you see. He's not on any narcotics, and he relates that he's actually been to the ER several times over the past 2 years, but now because of COVID, he wants to avoid the ER, and he's finally come to see you. So like a lot of the patients in the burden study also told us, they had not gone to see a provider. So he plans his life around bowel movements, and he hesitates to go to dinner with his wife, particularly after he's taken a laxative. He tells you he has a past medical history of a robotic prostatectomy about 2.5 years ago. He also has a history of hypertension on a thiazide and ACE inhibitor, and also hyperlipidemia. He's had 2 negative colonoscopies in the last 4 years, and he denies any family history of colon cancer, but his mother, brother, and wife all also have constipation. So right now what I'd like you to do is tell me what you think his diagnosis is. Do you think he has irritable bowel syndrome with constipation, chronic idiopathic constipation, pelvic floor dyssynergia, slow transit constipation, or you're not sure and you need more information? So please cast your votes on your iPad. All right, so the vast majority of you feel that 43% feel that he has chronic idiopathic constipation. Only 7% really feel like he might have irritable bowel syndrome. About a quarter of you feel like you're not sure and you need more information, and the rest of you picked the other alternatives. So the question is, does Richard have constipation? So these days we have the Rome 4 criteria for diagnosing constipation, and these criteria state that the patient must have 2 or more of the following at least 25% of the time. They must have straining or lumpy or hard stools, or a sensation of incomplete evacuation or anal rectal obstruction, or they may use manual maneuvers to have a bowel movement, and they need to have less than 3 bowel movements per week. Those criteria need to be fulfilled for the last 3 months, and they need to have had at least the symptoms for 6 months prior to diagnosis. Loose stools are rarely present in this population, and without using laxatives, and they do not meet the criteria for irritable bowel syndrome. So most of you didn't fall for the fact that he had bloating or discomfort, because sometimes you think of that as more of an irritable bowel syndrome symptom. And really what the Rome Foundation has also recognized in the Rome 4 criteria is that really this is more of a spectrum of symptoms. So bloating and distension could possibly be part of functional constipation, as well as irritable bowel syndrome with mixed symptoms or even diarrhea, and pain may be present as well. This point is very nicely illustrated in this study that was done in over 1,000 patients that met either criteria for irritable bowel syndrome with constipation or chronic idiopathic constipation. About 25% of the patients had irritable bowel syndrome, and the other 3/4 had chronic idiopathic constipation. And these patients were all questioned on a bunch of symptoms like abdominal pain and bloating. And while you see that the IBS patients generally had more severe symptoms. There in the green bars, they had more severe symptoms of abdominal pain, bloating, and even upper GI symptoms. There certainly was a fairly substantial population of patients who had chronic idiopathic constipation who also had these symptoms. And I think that this may reflect the fact that there are a subset of our chronic constipation patients that are probably in between irritable bowel syndrome and chronic idiopathic constipation. And while these patients don't meet the Rome criteria for IBS, these patients also may use more of our healthcare resources and have a poorer quality of life. So it's important to realize that there's overlap within the two syndromes. So let's take a look at the diagnostic algorithm for chronic constipation. This should be familiar to many of you. One of the things we want to do when we see patients is to make sure that they don't have red flags. If they have only occasional constipation and their symptoms have not been present for very long, they may just have occasional constipation, and you may want to treat these people empirically. If they have symptoms for greater than 3 months, they likely have chronic constipation, and then you then have to determine if they have primary or secondary constipation. And I think we've already discussed the concept of abdominal pain.
You know, Luce, I just want to jump in there for a second, because I think this whole issue about the distinction between IBS-C and chronic idiopathic constipation is one that we all grapple with in real-life clinical practice. And I think the point that you raise about patients with constipation oftentimes having abdominal symptoms is a really important take-home message. I think from a regulatory standpoint and from the standpoint of the Rome criteria, there's certainly a distinction, but I think we also all recognize that oftentimes when you follow patients longitudinally over time, at one point in time, they might satisfy criterion for IBS-C, but 6 months later, they might fulfill criterion for chronic idiopathic constipation. So it's fluid, dynamic, and to some extent, a bit arbitrary to draw the distinction between the two groups. And Michael, I know you've done a lot of work on this at Mayo Clinic as well. I don't know if you have an opinion you'd like to chime in on.
Yeah, thank you, Bill. Thank you, Lucy. I certainly agree with all of the comments that have been made, and this is really a spectrum. And I'll make two specific points. One is there was actually an epidemiological study done here at Mayo Clinic. The first author was Smita Halder, and may he rest in peace, Rick Locke and Nick Talley were co-authors. And what they showed was exactly what Dr. Che has mentioned, and that if you take the same person and you send a bowel disease questionnaire and you assess their symptoms 6 months or a year apart, you'll see that transition from one diagnosis to the other. The other, in other words, going from IBS constipation to chronic idiopathic constipation and vice versa. The other point I'll make is that what I find a little confusing is more than 25% of problems with evacuation. You know, if I see a patient in the clinic who says, 90% of the time I have to strain my heart out and I have to be on the toilet sitting there for 20 or 30 minutes. I have a second library in my restroom. Very often, you have to start thinking of the evacuation disorder as another problem that could be producing the same symptoms of bloating, constipation, and what I call secondary abdominal pain due to the defecation disorder. So I completely agree. This is a spectrum, and it is really important that we keep that spectrum in mind as we examine the patient and perform the investigations.
Agreed. Lucy,
Agreed.
Back to you.
All right, so let's talk about those red flags. I think you want to pay attention to weight loss, particularly if it's more than 10 pounds. If the symptoms start in someone over the age of 50, if they have a family history of colon cancer or inflammatory bowel disease or celiac disease, if they have rectal bleeding that's more than outlet bleeding, if they have anemia or fecal occult blood test and maybe abnormal chemistries, or particularly an increased C-reactive protein. But I also want to make sure that you understand that there are other elements of the history that are particularly important besides the red flags. And that's really to sit down and talk to your patient about the nature of their symptoms, how long they've been going on, what laxatives they've used. Maybe you handle that in a questionnaire. I think it's particularly important to take a dietary history, as well as to also question them about obstetric history and even a history of gynecological surgeries, because that certainly changes the way the pelvic floor relates. And sometimes in robotic patients, I've actually experienced that they have an increased problem with evacuation disorders. And then I also want to emphasize the point that it's really important to talk upfront and in the beginning about history of emotional distress or anxiety, because if you bring it up later, then the patient has the impression that you think that this is all in their head. And if you're bringing it up as kind of a global view, they are much less likely to think of that. In terms of secondary causes of constipation, there are all of these things to think of, but I draw your attention particularly to making sure their medications aren't causing symptoms, that they don't have a collagen vascular disorder, or that they don't have a neurological disorder such as MS and Parkinson's disease. We know from histories of these patients that often constipation is actually a sign that presents years before the actual neurological signs. The other diagnostic consideration, I think that we realize that the majority of our patients, as that tertiary referral practice shows, study shows that most of them have normal transit, and only a very small proportion of these patients have slow transit that might be myopathic or neuropathic in nature. But still, a significant proportion may have, as Dr. Camilleri has already alluded to, may have dyssynergic defecation or a rectal evacuation disorder. And this can involve not only an inability to relax the pelvic floor, but perhaps there's an incoordination between the abdominal and pelvic floor muscles, or there's an inability to produce the right forces to get the stool out. So we have another audience response question for you. And I'd like to know, what diagnostic testing do you think you need to order for Richard? Do you think he needs a digital rectal exam, a balloon expulsion test, an anal rectal manometry, a colon transit study, another colonoscopy, or you're not sure? So please again use your iPads to cast your votes. Right, very, very interesting. Almost 2/3 of you think that you should do a digital rectal exam. No one voted for a balloon expulsion test. That's interesting. Only 7% of you voted for anal rectal manometry. Thankfully, only a very few percentage of you voted for colonoscopy, and some are still not sure. So let's take a moment and talk about rectal evacuation disorders. So the first four choices on this slide are actually pretty much synonyms for the same thing, that there's dyssynergic defecation. There are patients, though, either elderly patients who have descending perineum syndrome. This can particularly present as like rectal and vaginal prolapse. But if you see this in a younger patient where you do the exam and they have a lot of descent of their perineum, you should possibly think of hypermobility or Ehlers-Danlos syndrome. So pelvic floor dyssynergia frequently overlaps with chronic idiopathic constipation. It's probably much more common in women. Most of you recognize that you can recognize it on a digital rectal exam, but you also could do a balloon expulsion test, but this is either well performed in either motility lab, or you even can do it in the office. High resolution anal rectal manometry can also be used to make this diagnosis. But let's take a moment, particularly if there are fellows out there in the audience, let's talk about the digital rectal exam. I think it's become a bit of a lost art. I'd like to make the point that, particularly in this day and age, it might be important to have a chaperone in the room when you do the exam. I think you also need to keep in mind that there are a certain percentage of these patients that have undergone, sexual abuse or physical abuse. So you need to drape them properly and explain the exam thoroughly. And the first part is really just checking for anal tone at rest, and then asking the patient to squeeze. And then also the second step, you want to insert your finger a little bit deeper so that you can really feel the squeeze of the rectum. And also you are also feeling posteriorly to see if you can feel the puborectalis muscle. And then the last step is that you ask them to bear down and try to push your finger out. And if they have dyssynergia, you will generally feel that that puborectalis muscle squeezing around your finger. But the other thing you should pay attention to is also the descent of the perineum. And we know from this study that the performance of the digital rectal exam is a very sensitive test. It has a positive predictive value of 0.97, and it also has very good sensitivity and specificity. So what other tests do we have? Well, we have the anal rectal manometry test, and it also senses strength and tone and sensation of the anus and the rectum. Balloon expulsion is usually part of the test. There are different ways of doing this, but what you're basically asking the patient to do is expel the balloon. And normal balloon expulsion usually occurs in less than a minute. And abnormal expulsion, I know it says greater than a minute in this slide, but some people use 2 minutes as a guideline. So testing techniques and body position and types of balloon can also be varied, and you can see also the traditional linear pattern versus the high resolution rectal manometry. Another exam is the pelvic of the pelvic floor is the defecating proctogram, and you can do this in 2 different ways. The barium defecating proctogram, I like it a little better because it's more physiologic. The patient is actually sitting on the toilet, but some people will also prefer the MR form that's done in the supine position, and you may want to use that when you are particularly interested in also what's going on in the pelvic area. It can be useful. So at this point, I'm going to turn this over to Dr. Camilleri to actually discuss transit studies.
Thank you, Dr. Harris. So the first very commonly used method to measure transit involves radiopaque markers. And there are essentially 2 techniques commonly used. The first is called the Hinton technique. And it's important to stress this is a qualitative test of colonic transit. Basically, the patient ingests 24 radiopaque markers on one day, follows a high fiber diet for 5 days, an X-ray is taken of the abdomen on day 5, and you count the number of markers remaining in the abdomen. And if 6 or more markers are retained in the abdomen, then you say that this patient has delayed colonic transit. It's possible that if all the markers are assembled in the left side of the colon or the sigmoid colon area, then it might suggest the presence of a pelvic floor dyssynergia. The second technique is the Amanda Metcalf technique, and it's more quantitative. So in this technique, the patient ingests 24 markers every day for 3 days, And usually a day 4 X-ray is taken, sometimes a day 7 X-ray is required. And basically you count the number of markers remaining in the abdominal X-ray, and that equates pretty closely to the number of hours it takes for the colon to empty. So let's say there are 54 markers remaining in the abdomen, then the colonic transit time is 54 hours. So that's how the radiopaque marker transit tests work. The Metcalfe technique is more quantitative. Other ways to measure colonic transit involve either whole gut scintigraphy or the wireless motility capsule. Now, with whole gut scintigraphy, an isotope is taken by mouth, either in a specialized capsule that dissolves in the distal ileum or in the liquid component of a meal during a gastric emptying test. You can radiolabel the solid and the liquid, and you follow the liquid as it goes through the colon. And what the images are showing you here is that between 8 and 12 hours, you can see, 6 and 12 hours, you can see that there is movement of the isotope from the right side of the colon to the ascending and transverse colon in the middle images at 12 hours. But in the lower panel, you'll see that in the patient with slow transit constipation, there's virtually no movement of the isotope out of the ascending and transverse colon. In contrast, in the patient with the rectal evacuation disorder, the isotope has moved completely out of the right side of the colon, and it's assembled, it's collected in the left side of transverse colon and the descending colon. So the imaging studies with radioisotopes can actually help you get a clue as to whether the patient has slow transit constipation or an evacuation disorder. The wireless motility capsule monitors the pH through the GI tract, and it has a temperature sensor, and so you can tell from the changes in pH, for instance, going from the ileum to the colon, the pH becomes a little bit more acidic, and so you can tell when the colonic transit has started, and obviously when the temperature of the capsule is the same as the environment, it drops from 98 or 37 degrees Celsius to the ambient room temperature, then you know it's exited from the patient's body. And so you can tell what the overall colonic transit is. And it's quite well validated, especially compared to the radiopaque marker transit test.
Hey, Michael, before we go on to talk about what the tests mean, I wanted to stop for a second here and just ask a couple questions. So the first thing is, when do you order these tests? You know what I'm saying? So we talked about making a diagnosis using symptom-based criteria, using the overlap between IBS-C and chronic idiopathic constipation. We've now had a very elegant discussion of what the tests are, but when do we order these tests? And the other question I want you guys to think about, and if you could answer for me, is in what order should we do these tests? Because I think there's confusion out there on both those points. So, Michael, maybe you could talk about the first thing, and then Lucy, you could talk about the second thing.
Well, I mean, I think the tests are ordered typically when the patient has symptoms that have not responded to first-line therapy. That's where I think obviously the digital rectal examination is a very important part of the evaluation, but to pursue the tests of anerectomanometry and transit measurements, I think I would want the patient to have gone through first-line therapy and not responded to those before I embarked upon the testing. And I'll hand it over to Lucy to determine what's the correct order.
You know, so one of the challenges these days is that we're not seeing a lot of patients necessarily in person. And, you know, so that's definitely a problem. I also like to do the anal rectal manometry to confirm my physical exam when I'm able to. Because some people, there are a few people that, you know, just can't do what you ask them to do when they're on their side. They can't imagine what it's like to actually push your finger out. So I definitely do the digital exam if I can, but in this day where we're seeing patients only on the video camera, I will ask them to do an anal rectal manometry, and I find that they're actually doing it more when I explain, about pelvic floor dysfunction. They'll actually go and they'll do the anal rectal manometry. They actually seem to be accepting it better because I can't, explain I can't examine them. So I use that, and then if I really have a feeling that a patient has slow transit, they're telling me they have bowel movement, every 7 days or once a month, or something like that, that's when I'll probably look more at the transit type studies.
Yeah, I think there's a couple of really important take-homes from this discussion. So the first thing is I completely agree that the time we're going to do physiologic testing is in patients that don't respond to either OTC or prescription laxative therapy. Now, once you make the decision to pull the trigger on physiologic testing, you should evaluate the pelvic floor and for dyssynergic defecation first. And the reason why is because if you order a colonic transit study, it doesn't matter which one you order, if you order a colonic transit study and it comes back abnormal, you will not be able to interpret whether that represents slow transit or dyssynergic defecation or some other form of an evacuation disorder unless you've evaluated the pelvic floor first. So all of the guidelines say start with anal rectal manometry, balloon expulsion testing. If you don't have that, you could do defecography or defecating MR. And then the last tip I'm going to give you is this. There's a lot of discussion about that if you see all the markers accumulate in the left side of the colon, that means you have dyssynergic defecation. And if they're evenly distributed through the colon, that means that you don't. That's partially true and partially false. Okay, so here's the thing. There's a nice study from Asia. We've also published on this as well. And the bottom line truth on that is if you see all the markers accumulate on the left side of the colon on, for example, either Hinton or Metcalf on the abdominal x-ray, that increases the likelihood that there is a form of an evacuation disorder. But realize that most patients with an evacuation disorder do not aggregate markers in the left colon. So while it's relatively specific, that finding, it is not sensitive. So you can, in other words, if you see the pattern, great. You definitely think about an evacuation disorder. If you don't see the pattern, that doesn't mean they don't have an evacuation disorder. All right, so Michael, back to you.
Thanks. And actually, I often use that information, Bill, to kind of confirm my clinical examination findings. So I use it to corroborate the whole picture in the patients with rectal evacuation disorder. But I completely agree with your recommendation. So the patient underwent an anal rectal manometry and balloon expulsion tests, and the resting anal sphincter pressure that is reflecting the internal anal sphincter is normal. The maximum squeeze sphincter pressure that reflects the external sphincter, which is under voluntary control, that's also within the normal range, and it more than doubles the resting pressure, which is a number I like to use clinically. Now, this is the important point. If we're thinking about an evacuation disorder, the residual anal pressure is within the normal range, and in fact, the anal sphincter is able to relax normally. And the difference in the pressures within the rectum and the anal canal has a higher pressure than the rectum, and that's quite normal. That's what you want to maintain continence. But the patient's number here is well within the normal range, and the patient is able to produce a good abdominal compression, a good Valsalva maneuver to raise the intrarectal pressure to expel contents from the rectum. So that, I think, is a very good evaluation that explains why the balloon expulsion time is 15 seconds, which, as Dr. Harris mentioned, is well within the normal range. Now, to reiterate the point that Dr. Che made, the colonic transit time is helpful, it's useful, but it needs to be looked at in the context of the whole clinical picture, and particularly the anal rectal manometry and balloon expulsion. So among patients with chronic constipation, normal transit with an abnormal balloon expulsion or anal rectal manometry suggests a defecation disorder. Slow colonic transit with a normal balloon expulsion test suggests slow transit, whereas in the presence of slow colonic transit and abnormal balloon expulsion or anal rectal manometry, that, in my mind, and just to reiterate what Dr. Che has mentioned, first thing you need to think of is the defecation disorder is primary and the slow transit is secondary to the defecation disorder. Now, yes, occasional patients, you'll treat the defecation disorder and they'll also have slow transit constipation, but that is a rare occurrence clinically. Lucy, let me ask you, what about breath testing and methane testing in the breath?
Well, that certainly is a very controversial area. But, some of us are doing breath testing in our patients with constipation, particularly when they're talking about bloating, looking for small intestinal bacterial overgrowth. And then I think some of us have also been told in the past that methane might be associated with slow transit constipation, and you're usually looking for levels of greater than 10. But I think that we need to be aware of some research about the fecal biome. Paris Rothi, and forgive me if I just massacred his or her last name, but they did some work on the fecal microbiome, testing both the mucosal and the luminal fecal biome, and they found that there was an increased amount of Bacteroidetes, bacteria in patients with chronic idiopathic constipation as opposed to those with healthy controls. And they also found that the bacteria were more predictive of slow transit, and it wasn't the methane levels. So I think we need to stay tuned and see what also the fecal microbiome might teach us as well.
Fantastic. Now, before we go on, there are a whole lot of questions that are coming in, so maybe we'll just do a couple. I think we're doing okay on time. So the first one is, when and in what patient would you think about doing Hinton versus Metcalf? Michael, I don't know if you have an opinion on that. I certainly have one, but let's start with you.
I think I would always do Metcalf because it's quantitative and, just so that gives me an approximate level to which that colonic transit is slowed. So that's what I would choose. Yeah,
and I think I would agree that particularly for a tertiary care center where you have a dedicated physiology laboratory, and particularly where you're handling patients in which you might think about surgical intervention, you should always do Metcalf. But for the average person in private practice that has limited infrastructure, is just trying to get a better idea about whether somebody has slow transit or not, and whether they need to refer the patient on to somebody like the three of us, I think Hinton is more than adequate. So what I would say is for the community gastroenterologist, Hinton is fine. For the tertiary quaternary care gastroenterologist, really should be doing Metcalf. All right, another question here. Is there a reason to wait greater than a minute when doing a balloon expulsion test? I think that's an interesting question. Lucy, what do you think?
I think that, yes, there is. I think longer expulsion is truly usually predictive of a pelvic floor dysfunction. So,
yeah, I would say that, again, like in tertiary care, if you have the luxury of waiting, but really, here's the thing that I think is interesting. This is my opinion, but it's my opinion based on our research, work from our lab, is that actually a minute is quite long. And it turns out that when you look at normal individuals with absolutely normal anorectal manometry, balloon expulsion, defecography, that they actually aggregate in less than like 25 seconds. It turns out that a minute is actually quite generous in terms of being able to get the balloon out. So I would actually argue that you don't have to wait for more than a minute, but I think it depends.
Well, I think our nurses in the motility lab are very good at, discussing with the patient, because there is that occasional patient that just is really anxious about the whole test, and that may be the situation. But, one other point I'd like to make about assessing transit in our patients is, unfortunately over the course of my career, I've seen patients that haven't had transit studies and they've had colectomies and then they have pelvic floor dysfunction. And there's the ability to take out the colon obscures the fact that they can't still have bowel movement.
Couldn't agree more. Yeah, anytime you're even contemplating the possibility of doing a colectomy, you must evaluate the pelvic floor and do a colonic transit study. And I think any of the studies that Michael so nicely outlined are reasonable, but you must have in hand a study with a normal pelvic floor that shows a clear delay in colonic transit. Michael, I don't know if you agree with that, but that's my opinion.
That's absolutely right. And, in our experience, unfortunately, we have seen some patients who present with constipation after having undergone the colectomy, as Lucy Harris has mentioned. So that's absolutely, to get the physiological testing is mandatory before considering colectomy.
Yes.
Or indeed an ileostomy or a colostomy.
Agreed.
We'll talk more about it, but I think that after they have colectomy, we often send them back to the pelvic floor physical therapist just to reteach them defecating, because sometimes they have problems after surgery anyway.
Okay, let's go back to our patients. So results indicate, there we go, let's see, there we go. Results indicate that Richard does not have an anorectal evacuation disorder. He exercises regularly, is well hydrated, and consumes an average of 25 grams of fiber per day. Which approach would you recommend for Richard? Choice A, conduct a colonic transit study. Choice B, different over-the-counter agent, such as fiber supplements, stool softeners, or laxatives. Choice C, prescribe a therapeutic agent, which is a prescription medication, such as lubiprostone, linaclotide, plecanatide, or prucalopride. Or choice D, you're not sure. What do you think? Okay, so it's 47% choosing prescribing a prescription medication, 33% using some alternative over-the-counter medication, and 13% not sure what they would do here. So let's see if we can add some certainty to your treatment algorithm. All right, so we're going to talk about treatments for chronic idiopathic constipation. We're going to start off with a brief discussion of over-the-counter agents, so osmotic and stimulant laxatives. And you can see that there have been a number of osmotic and stimulant laxatives which have been studied in randomized controlled trials and have actually been recommended in clinical practice guidelines addressing patients with chronic idiopathic constipation. Specifically, polyethylene glycol and lactulose have both been evaluated in randomized controlled trials. One fun fact about lactulose, it's the only agent that's been evaluated in randomized controlled trials for pregnant women. So in pregnant women, the only evidence-based treatment is actually lactulose. In terms of over-the-counter stimulant laxatives, bisacodyl and sodium picosulfate, which are chemically related, of course, are both evidence-based. They've both been evaluated in 4-week randomized controlled trials showing clear benefits in terms of improving stool frequency. Now, that's not the end of the story, though. You can see on the slide there are many other choices. So in that osmotic category, one of my own personal favorites is magnesium oxide. I think magnesium is a very effective and very safe oral over-the-counter laxative treatment. And also in terms of the stimulant laxatives, agents like senicides, cascara, and most people don't realize that rhubarb and aloe are both stimulant laxatives. In terms of the patient experience, in this survey of over 1,400 individuals, 70% reported trying more than one over-the-counter medications during the past 6 months. So over-the-counter medication used for chronic constipation, very, very common. 19% reported trying greater than one over-the-counter medication. And then 44% had tried and stopped one or more medications. So unfortunately, almost half of these patients did not achieve a successful outcome with the over-the-counter remedy that they chose. 30% had tried and stopped one or more medications due to insufficient relief of their symptoms. Very few patients were very confident they could predict the timing of their bowel movements. This is one of the biggest complaints for patients, is the unpredictability of their bowel habits, and more specifically, the unpredictability in regards to their over-the-counter laxative treatment, particularly osmotics. A high proportion of patients who report stopping OTC medication due to insufficient relief of their symptoms suggest patients may be cycling through multiple medications in the hopes of finding one or more than one that provides them with some relief. So to lead us through the discussion of prescription medications, I'm going to turn this over to Michael.
Thanks, Bill. So this slide summarizes very nicely the two main classes of prescription medications. So let's focus first on the secretagogues on the left side of your slide. And there are four important ion channels or ionic exchange mechanisms on the epithelial cell, on the surface of the epithelial cells in the small intestine in particular. So let's start with these mechanisms. First of all, going from left to right, you see the guanylate cyclase receptor, the guanylate cyclase C receptor. Now, this normally responds to the presence of substances that are produced by different types of cells in the intestine, like guanylin and uroguanylin. It's also the same receptor that responds when we have an infection with E. coli enterotoxin that causes acute severe watery diarrhea. So guanylin and uroguanylin serve to hydrate the content of the lumen, but also they can be stimulated by the guanylate cyclase C activators, linaclotide and plecanatide. And we'll look at the efficacy of those treatments in the next few slides. What happens after the guanylate cyclase C receptor is activated is that there are intracellular messengers that take the message of stimulation over the CFTR, which is the cystic fibrosis transmembrane regulator. And through that channel, chloride, and because of the chloride coming out of the cell, sodium and water, come out into the lumen and hydrate the content or increase the water content within the lumen. Now, there are two other ionic exchangers that I want to talk to you about. One is on the extreme right of that cell, you see another chloride channel. This is a chloride type 2 channel, which responds to the other medication we're going to talk about as a secretagogue, which is lubiprostone. So all those three, linaclotide, plecanatide, and lubiprostone, result in increased chloride secretion. On the other hand, the sodium hydrogen exchanger, NHE3, is inhibited by the drug tenapanor. So what that does is it keeps more sodium in the lumen, and based on osmotic gradients, water comes out of the lamina propria vessels and into the lumen to keep that osmotic gradient as neutral as possible. So tenapanor works by preventing sodium absorption, keeping the sodium in the lumen, and adding water in the lumen. Now, what about the pro-motility types of agents? Well, the main factor we're going to talk about here is serotonin. Serotonin is normally produced, as you all know, from the enteroendocrine cells. It activates the intrinsic primary afferent neuron, which is mediated through acetylcholine and calcitonin gene-related peptide. It stimulates peristalsis. So essentially, the intrinsic serotonin is going to activate those cholinergic neurons to cause contraction above a bolus and therefore induce peristalsis, movement downstream of the content within the lumen. In the same way that the endogenous serotonin can stimulate that cholinergic neuron, similarly, exogenous administered serotonin 5-HT4 receptor agonists, such as prucalopride, will stimulate that same cholinergic neuron to induce peristalsis. And so those are the mechanisms that result in the pro-motility or laxative approaches that we see in clinical practice. Let's look at the efficacy of some of these medications. First of all, lubiprostone. This is a non-absorbable, GI-targeted, functional bicyclic fatty acid. It selectively activates the type 2 chloride channels, which I explained on the previous slide. You get chloride and water secretion, and incidentally, it also has a beneficial effect on mucosal barrier function. The dose for chronic idiopathic constipation, the approved dose is 24 micrograms twice a day. For irritable bowel with constipation, a slightly lower dose of 8 micrograms twice a day. Important to take this with food and water. The side effects are nausea, diarrhea, and headache. In my experience, the nausea often abates over a few weeks, and so the patients become more tolerant of the side effects of that medication. How effective is it? Well, this slide shows that the lubiprostone can reduce the symptoms of the patients. The stool consistency is improved, the straining is improved, and the constipation severity, these are all improved. You'll also notice, and I'll come back to this point later, that these trials for lubiprostone in chronic idiopathic constipation, which were done several years ago, were conducted usually for a period of 4 weeks. And this differs from some of the other trials that we'll be discussing. The next drug we want to talk about is linaclotide, which, as I mentioned, is a guanylate cyclase C agonist. It stimulates secretion of intestinal fluid. It may also reduce intestinal pain, at least from studies that have been done in animal models. The dose that's approved for treatment of chronic idiopathic constipation is 72 or 145 micrograms per day, and the side effects are diarrhea and abdominal pain. Linaclotide is therefore very often used to help with the patient's constipation. And similarly, another medication is plecanatide. Plecanatide is not a guanylin analog like linaclotide. It is a uroguanylin analog. They differ slightly in where they work in the GI tract. So uroguanylin tends to work higher up in the small intestine, where the pH is not quite so alkaline as in the distal ileum, for example. So uroguanylin, theoretically at least, has an advantage that it will start inducing that secretion of chloride, relief of the constipation, perhaps by pushing more water into the intestine from higher up in the small intestine. So it has binding efficiency at those lower pHs, which typically are around 6.2 or slightly lower in the duodenum and proximal jejunum, whereas the ileum, the pH goes up to 6.8 or even 7. The dosing with plecanatide is 3 milligrams per day for adults with chronic idiopathic constipation, and it may also cause diarrhea and abdominal pain as side effects. What about its efficacy? As we saw with linaclotide, there is considerable efficacy with relief of the symptoms such as the complete spontaneous bowel movement responders. Over the years, the endpoints used in these trials have varied in some respects because the FDA has required more stringent endpoints. So in the case of plecanatide, for example, the responder is defined by an individual that has more than 3 complete spontaneous bowel movements per week, more than baseline, and that this has to be a durable response, typically for 9 out of the 12 weeks of a study. So these are, and the same sort of levels and differences from placebo were noted with both linaclotide and plecanatide using those very stringent endpoints in the clinical trials. Prucalopride, as we mentioned, it's a selective 5-HT4 receptor agonist. It has colonic prokinetic activity. It improves colonic motility, decreases colonic transit time, and increases complete spontaneous bowel movements. It's important to note that prucalopride, in contrast, for instance, with some of the other medications which we will mention, is not active against the blood vessels, and it's not having an effect on the heart. 5-HT4 receptor agonists like cisapride, for example, there were some concerns, there were significant concerns about cardiac arrhythmias due to stimulation of the hERG channel, but that has not been observed with prucalopride. So the dosing with prucalopride in adults is 2 milligrams per day for chronic idiopathic constipation. If the patient has severe renal impairment, by which we mean a creatinine clearance of less than 30 milliliters per minute, then the dose should be reduced to 1 milligram per day. The side effects are headaches and diarrhea. So how efficacious is prucalopride for chronic idiopathic constipation? Again, these are studies which were done several years ago. There were 6 randomized controlled phase 3 studies performed in several different countries. And what one noticed is that using the endpoint of more than 3 complete spontaneous bowel movements per week over a 12-week treatment period, the patients treated with prucalopride 2 or less milligrams per day had a greater proportion of responders, both among men and among women. And the difference is about 15 or 16%, similar to the typical difference one sees with the rigorous FDA endpoints with the secretagogue. So in general, the number needed to treat for most of these medications is approximately 4 to 6. The cardiovascular safety of prucalopride is important to note, and I started to introduce this earlier. So the first generation 5-HT4 receptor agonists like cisapride and tegaserod were withdrawn from the US market because of cardiovascular risk concerns. Whereas prucalopride is a selective 5-HT4 receptor agonist, it does not interact with the cardiac hERG channels, hERG potassium channels, or with other serotonergic receptors in blood vessels. Now, most of you will know that tegaserod has now been reapproved in recent years reapproved by the FDA, and it is indicated for patients who have irritable bowel syndrome with constipation under certain restrictions. So important to make the point that there are no increased risks of major cardiovascular events in patients with chronic idiopathic constipation taking prucalopride. Now, the next slide shows the data supporting clinical decisions in chronic idiopathic constipation. Unfortunately, there are no head-to-head comparisons among all of these medications, whether they're secretagogues or pro-motility agents. And so one way in which one can try to find out which are the most efficacious among these medications is to conduct a formal network meta-analysis of the randomized controlled trials. So there were 17 trials and one randomized controlled trial that reported the data, and the way in which it's expressed in this forest plot, it's expressed as a negative, if you wish. It says if you fail to achieve 3 or more bowel movements per week, then you're closer to that line of identity which you see corresponding to the 1.0 mark in the forest plot. And the endpoint that was used in these studies to compare, essentially you're comparing each drug against placebo and seeing how much better that drug is compared to placebo, and then trying to put them in a league table. That's how the network meta-analysis is done. So the objective endpoint for all of these studies being evaluated was achieving 3 or more complete spontaneous bowel movements per week at weeks 8 to 12. And so this is a large experience when you look at all the trials together, almost 9,000 patients randomized to treatment and about 4,650 patients to placebo. So the first important point is that all treatments were actually significantly better and more effective than placebo. And if you use this metric, you find that at the top of the league table, prucalopride ranks first among these treatments. So, this is one of the ways in which you can try to assess relative efficacy, but of course, it is not a head-to-head comparison between any of these agents with another active treatment. And so let me now turn it over to Dr. Harris. Dr. Harris, Lucy what about this patient? What if his anal rectal manometry had been positive? What would you have recommended?
Well, there are some methodological differences in the way that this is done, but generally speaking, when pelvic floor therapy is done correctly, about over 70% of patients will respond. And generally at our institution, we start out with patient education about constipation and about how the pelvic floor works. Then the nurse educator works with the patient to train them to relax their puborectalis muscle, and the patient practices simulated defecation by using the balloon expulsion test. You should remember that most people with pelvic floor dysfunction actually are female patients. So.
Let's do a little discussion first. A couple questions here. Before we go on to the next section on integrated care, let's go through some of these questions that are coming in. So the first question is, what about probiotics? And it's fair, we haven't spoken about probiotics. I guess that's in the over-the-counter section, so I'll take that on. And bottom line right now is we have very little credible data supporting the use of probiotics as a treatment for chronic constipation. So right now, I think you'd be hard-pressed to make a recommendation, an evidence-based recommendation on regarding probiotics for constipation. Does that mean that the strategy is dead in the water? No, not necessarily, but we really need appropriately powered, methodologically rigorous studies to give us a better idea about whether this is valuable or not, and we just don't have that. There are some natural therapies for chronic constipation that can be highly effective, so I think everybody's probably very aware of prunes, as well as dietary fiber supplementation. Right now, the most evidence-based fiber supplement is probably psyllium, although there are other fibers that may well offer benefits as well. In fact, it's really interesting to think about. Psyllium is a soluble gel-forming fiber, but prebiotic fibers like inulin, for example, that lead to the production of short-chain fatty acids, which create an osmotic load, can also be beneficial for some individuals as well. So the fiber discussion is actually an interesting and complicated one. Another question here was about health disparities and how that might impact on constipation. And in fact, it is true that constipation tends to be more common amongst individuals of lower socioeconomic status. And you have to wonder whether or not diet plays a role, because it's obviously much more expensive to eat quote unquote healthy, to eat a lot of fruits and vegetables. And I have little doubt that that probably does impact on some patients' symptoms. All right, so let's go on to our next section, or our first an ARS question. So what would your treatment choice be for Richard? Choice A, lubiprostone. Choice B, linaclotide. Choice C, plecanatide. Choice D, prucalopride. Choice E, anorectal biofeedback. Or choice F, I'm not sure. All right, so 43% choosing anorectal biofeedback, and as I recall, we're now saying that Richard has an abnormal anorectal manometry, I believe. And if that's the case, I would agree with the audience. All right, so developing an evidence-based treatment strategy for patients with chronic idiopathic constipation. That's our first question here. How would you describe your interdisciplinary integrative care network for patients with chronic idiopathic constipation? First choice, challenging for my community-based practice. Second choice, improving, but still has a way to go. Third choice, I need strategies for building my network. Fourth choice, I'm fortunate to have a strong network. Or last choice, fifth choice, what's an interdisciplinary integrative care network? So the vast majority saying either challenging for my community-based practice or I need strategies for building my network. And I do think this is completely consistent with the rest of the country. I think right now, integrated care is such a promising possibility, but the operationalization of it in people's day-to-day lives is challenging. Because here's the thing is, I think there's little doubt in 2021 that I think most gastroenterologists agree that treatment of patients with functional disorders, including constipation, has to extend and include things beyond medications. We've focused a lot on medications, but the reality is that dietary strategies, behavioral strategies, maybe even complementary alternative medicine therapies can be very, very helpful. And of course, in patients with chronic idiopathic constipation, as we've talked about, pelvic floor dysfunction may play an important role, and physical therapy and biofeedback are also going to play a very important role. So what you can see from this Venn diagram is the fact that oftentimes patients require more than one form of therapy to achieve the optimized outcome. And it really brings to mind this slide, which is the evolution that's occurred over the last 20 years in the care of patients with disorders of gut-brain interaction, again, including, and in particular, patients that have chronic idiopathic constipation. If you think about traditional GI care, which is what I came up in when I was a GI fellow 30 years ago, it really focused on patients seeing a primary care or a gastroenterologist, and that physician, that provider, trying to choose the right over-the-counter or prescription medication to try to address the patient's complaints of chronic constipation. That has gradually evolved through a lot of labor by a lot of groups around the world, showing that things like physical therapy and biofeedback training, showing things like behavioral therapies, showing things like diet therapies can be beneficial for patients with disorders of gut-brain interaction. Now, that's interesting, and in fact, all the studies look at individual interventions in patients with chronic idiopathic constipation. But as I just said a moment ago, oftentimes patients require more than one intervention. And unfortunately, what's happened for many parts of the country is that while you'll utilize a multidisciplinary approach, i.e. you'll get a consultation from a dietitian or a behavioral therapist or a physical therapist, they all work in their own silos. They don't come up with an integrated plan. They don't necessarily communicate effectively with one another. So multidisciplinary care, which is a clear step up from traditional GI care, falls short of the pie in the sky, which is integrated care. And that is where there is an interdisciplinary approach to develop a plan that takes into account these various parts of the formula to the extent that they may be relevant to an individual patient. So integrated care gets us more towards personalized health care. And that's fantastic. It's wonderful to talk about that. In fact, people like me have been talking about this for many years now, without evidence, until the publication of this study. This is the MANTRA study, a multi-center randomized controlled trial that was conducted in Melbourne, Australia. Actually, it was in Australia in general. It was centered in Melbourne, Australia. But this was a study that directly compared outcomes in patients with disorders of gut-brain interaction or functional GI disorders who were randomized to either usual GI care or integrated care. Now, it's worth mentioning that the usual GI care wasn't really usual GI care, at least as it compares to the United States, because individuals in this usual GI care arm saw a gastroenterologist, and the gastroenterologist developed a treatment plan for the patient with DGBI, but they could order a consultation with a dietitian or a behavioral therapist as long as the dietitian and behavioral therapist were outside of their health system. The integrated care arm, the patients were actually seen by a multidisciplinary collaborative team consisting of a gastroenterologist, dietitian, a behavioral therapist, psychiatrist, and physical therapist. And so those providers worked together. They saw the patient together, and then they developed an integrated plan together. And look at these outcomes. If you look at the global symptom scores, 57% enjoyed a significant improvement in global symptom scores in the usual care arm. Not bad, by the way, 57%. But 84% reported a significant improvement in global symptoms in those individuals who were randomized to the integrated care group. So the integrated, and that was obviously highly statistically significantly different. And in addition, the cost per improved patient was reduced with integrated care compared to traditional GI care. I'll say that again because it's a bit surprising. The cost per successful outcome was reduced by integrated care, not increased, reduced by integrated care. And finally, quality of life measured by EQ5 also improved in the integrated care group to a greater degree than usual care. So I'm going to turn the mic back over to Lucy to talk about improving patient-provider relationship.
So in these days, we're faced with many challenges. We have less time to spend with patients. Average time has gone from 45 minutes to less than, to about 12 minutes. I think our patients see that the art of medicine kind of has disappeared, that we have, where there's a lot of problems with patient satisfaction. And I think that we've all been faced with the technology within our practice with the electronic medical record, and that makes it very difficult to even manage the dynamics of how you talk to the patient. You have to consciously make the effort to speak to the patient and not to the computer. Also, there's more time for us to spend on documentation, on getting prior authorizations, and our patients are increasingly dissatisfied with us because of that. So I want to emphasize again that it's important, just like with irritable bowel syndrome, to provide a clear and confident diagnosis. Tell the patient that they actually have chronic constipation. Don't waffle about it. And also engage them in a conversation. This is about shared decision making. So oftentimes what I'll do is I'll try and figure out what their biggest concerns are. I may offer a couple of suggestions and get their feedback and also their understanding of what their condition is. And so I think it's very important to encourage this collaboration, and I'll again make the point that it's really important to find out the whole biopsychosocial picture of what their mental health is, as well as what their physical health is, because this is the kind of discussion that actually builds up mutual regard and empathy, and really engages the patient and results in their patient satisfaction. So I'm going to turn it over to Bill, who maybe wants to discuss further.
Yeah, so the summary from tonight's deliberations: make a confident diagnosis of chronic idiopathic constipation using the Rome 4 criteria, and appropriate diagnostic testing and interpretation. And of course, we're going to reserve most of the testing for situations where patients don't respond to an over-the-counter and/or prescription medication. We're going to initiate evidence-based treatment in order to address symptoms that persist despite an initial dietary or over-the-counter approaches. we're going to think about and try to incorporate interdisciplinary integrative care strategies that facilitate comprehensive management of chronic idiopathic constipation. And we're going to establish a relationship with each patient by educating, providing empathy, and empowering to take an active role in the decision-making process. We have plenty of time for questions and answers. I'll start with a couple of statements, because one question here has been, the whole integrative care discussion is fantastic, but obviously, as the question we asked the audience shows, people are really struggling to try to operationalize and implement this in real day-to-day life. And I'll give myself a shameless plug by saying that I'm going to talk about this in detail tomorrow during the Edward Burke lecture. So I'm going to talk about irritable bowel syndrome as a great example of the evolution of integrated care and how we can scale integrated care on a practical level, particularly for community practices in places like the United States. Because the reality is, a small private practice is never going to be able to have enough volume to support a dietitian, a behavioral therapist, a physical therapist. So there are ways, particularly using mobile apps and digital platforms, to be able to deliver those types of care to your patients, and they'll become even more prevalent and more effective in the coming years. In fact, it's stunning to think about how the delivery of care to patients with DGBIs and digestive disorders in general is going to evolve and rapidly change over the next 5 years. And I'll talk about that in great detail tomorrow. So let's do a few questions and answers here. So one question here: which agent would be best for a patient with Parkinson's disease? So patients with neuromuscular disorders, maybe we can hear from both of you. Lucy, I know that's an interest of yours. Patients with Parkinson's disease, what would you recommend, since constipation is so incredibly common in those patients?
Well, that's important, and I've gone through the personal experience because my mom had Parkinson's disease, and often what they run into is that they have overflow incontinence. So you have to kind of balance having a bowel movement with, making sure that they, don't have some element of pelvic floor dysfunction. I think that's where medication like prucalopride or very judicious use of low doses of the guanylate cyclase drugs, or maybe a small dose of lubiprostone, so you're making sure that they don't have stools that are too loose. So those are tools that I do. Maybe also incorporating a little bit of fiber to take up the excess fluid in stool. Michael, do you have a comment on that?
I completely agree with Lucy's point. Just to remind ourselves, anorectal dysfunction is extremely common among patients with Parkinson's disease. And the classical studies were done by Ron Pfeiffer and Eamon Quigley many years ago. So, there is an evacuation disorder component, and then it becomes even more complicated, as Lucy is mentioning, if there is also anal sphincter dysfunction. And my preference is, for that reason, is not to use heavy secretagogue medications, but rather to use, first of all, over-the-counter stimulants like you mentioned, Bill, and then, if necessary, resort to prescription medications that stimulate colonic motility.
How about, there's another question here too about the use of abdominal films in your patients with constipation. Do you ever use those? Lucy, do you ever do abdominal x-rays?
Well, sometimes I will look if they've had a CAT scan and just see how much stool is around. I know that there's been controversy about the flat plate really being reflective of how much stool there is, but sometimes when you can see all the multiple levels, in a CAT scan, and there's just stool everywhere, you have to think that maybe that might have some impact on that they actually do have some increased fecal load. Yeah. So,
Michael, what do you think?
Well, Bill, this is again one of those shameless self-advertising moments. So we actually have done several studies showing that if you look at the coronal imaging on the CT scan, or much more simply, you look at the plain abdominal film, you can see a gas bubble in the pelvis, above the symphysis pubis, below the level of the sacroiliac joints. And if you can measure the surface area of that gas bubble in the pelvis, and it's greater than 9 square centimeters, we have shown that there's a 70% likelihood that that patient has a rectal evacuation disorder, even before you've put your finger into the anal canal to do a digital rectal examination. So if you're going to do, first of all, if the patient has already had a CT scan of the abdomen, please look at it. And if not, it's relatively inexpensive to do a flat abdominal X-ray, look at the stool load throughout the colon, as Lucy has mentioned, and also look at the gas bubble in the rectum.
Yeah, I think that's really interesting
Yes,
advice,
that's a very
Michael.
good
Thank you.
point.
You know, this is how I use an abdominal film. When I'm seeing a patient for the first time with chronic constipation, they come in the office, and I decide on a laxative regimen that I want to start. If a patient comes in and they say they're very, very constipated, you know, they have a bowel movement a couple times a week or once a week, I will oftentimes do an abdominal film as a decision node to decide whether I want to purge the patient before initiating laxative therapy. You could make the argument that if they're that constipated, just go ahead and do a purge and don't even do an abdominal film. But my logic is this. Particularly if you're using an over-the-counter remedy like an osmotic laxative, if a patient's colon is completely inspissated with stool, putting a dose of Miralax into it is literally like peeing into a bucket. You know, so the point is, if the colon's full of stool, go ahead and give a couple bottles of magnesium citrate or a colon prep, clean the colon out, and then initiate your therapy. The patient's much more likely to get a faster response and also to think that they've achieved a successful outcome. I mean, it's anybody's guess how long it takes, likely days before you're likely to see a benefit if you initiate standard over-the-counter remedies in a colon full of stool. How about,
one point? I also use the abdominal X-ray to educate the patient.
I agree,
To show where's
100%.
the colon and
Yeah,
where the stool is loaded and all of that.
I completely agree. I think it's very helpful that way, particularly for the patients that have a mixed bowel pattern, where you're convinced that some of it's overflow, but the patient's saying to you, but I have diarrhea, you know, every week. How can I be constipated? There's no way. When you do an abdominal film in that situation again, and the colon's all full of stool, it's very easy to convince somebody that they are in fact constipated. How about some of these new things that are coming down the pipe, like the vibrating capsule, for example? Do you guys have a comment on that as we start to wind down here? I mean, I think this is an interesting concept. You know, they've just completed some studies. The phase 3 data isn't out yet, but you know, could it be possible that mechanical stimulation could lead to improved stool frequency?
You know, to that point, it's probably a little more cost effective, but I have sent some, and there are some studies on visceral massage therapy.
Yeah.
I have a visceral massage therapist that I send my very constipated patients to, and she does get some results, and they get some bowel movements. I don't know, I'd like to see the cost data on a vibrating capsule too. I mean, I can't see that that's particularly cost effective.
Yeah, I don't know, Michael, if you have an opinion.
Well, again, we're all waiting with bated breath for the results of the studies, but I've always felt that coordinated contractions, high amplitude propagated contractions are important. And I'd love to see whether a vibrating capsule can actually induce those types of coordinated contractile activities to help propulsion of stool.
Yeah, it's an interesting concept, though, isn't it? How about, maybe this would be our last question here. We got a question just now. How about misoprostol? Is anybody still using misoprostol for chronic constipation?
I recently saw a patient who'd been taking it, and I had almost forgotten about it.
Right.
But
Yeah.
basically, It's a prostaglandin agent that is going to be inducing secretion.
Yeah.
And if patients tolerate it and they have no adverse effects, I told the patient that it's fine to continue it.
How about acupuncture? Do you ever recommend acupuncture for patients with constipation?
I haven't done that, not for constipation, maybe for pain, but.
Yeah. So two randomized control trials for acupuncture with chronic constipation. One a very large one, over 1,000 patients, was published in the Annals a few years ago now, showing an increase in complete spontaneous bowel movement rate. So there is some data. Actually, it is really a very high quality study, that acupuncture versus sham acupuncture. But again, a lot of it is cost and access because insurance doesn't cover that. It's mostly, almost always cash on the barrel. So I'd like to thank both of my partners in crime here, Lucy as well as Michael. Before we take, or as we finish up the program tonight, I just want to make sure that you fill out your course evaluation forms, and also make sure you add in the information if you want to get your mock points. But thank you very much for your attention, and we hope you enjoy the remainder of the meeting. Thank you.
Thank you.